This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
We have sort of a long outline. I want to give you an idea of the theoretical rationale behind our project, and then especially go over the characteristics of young boys with Fragile X syndrome, because they have some really interesting behaviors that really impacted the way we designed this intervention study. Wendy's going to spend some time talking to you about challenging behavior in boys with Fragile X, which really led us to come up with this idea of having a collaboration between speech-language pathologists and board-certified behavior analysts in implementing this intervention. And because of the low incidence of this disorder, in order to make the intervention accessible to the largest number of families, we decided to implement it using distance teleconferencing, which is also one of Wendy's areas of special interest. Then Ashley's going to tell you a little bit about our current research project, in which we 10 boys, young boys with Fragile X and their moms participated, and we are in the process of analyzing the results, but Ashley's going to tell you about results for 3 of the mother-child dyads, and then we'll talk a little about future research. And then in our interactive discussion segment later on, we are going to go into more details about the language component of the intervention, the behavioral component of the intervention, and the collaborative aspects of the intervention program. And we have a lot of video clips which we hope will make it really interesting for you to understand what we did. So I want to start out talking about the fact that from the beginning, we wanted to implement an early language intervention, but we wanted it to be a parent-implemented or parent-mediated intervention, which means that instead of the interventionist working directly with the child, that the interventionist would actually work with the mom, and then the mom would in turn work with the child. So the mom's behavior actually mediates the relationship between what the interventionist does and what the child is learning. So we know that the ways in which parents interact with their young children are very important for lots of different aspects of development, so social development, cognitive development, and especially language development. And certain characteristics of the ways in which parents talk to their children can really support and enhance a child's language learning. So parent speech that incorporates these characteristics that have been identified as impacting language development positively is called verbally responsive. And a definition for verbally responsive language is that it's prompt, contingent, and affectively positive verbal responses to child acts of play and communication. And the basic notion behind the idea of teaching parents to use verbally responsive language input with their children is that when you talk about your child's focus of attention during play or other daily routines, or when you respond contingently to child communication acts, you create a situation in which the child is more easily able to learn the language that maps onto what he's interested in or what he's doing or communicating about. So we had 2 basic strategies that we were targeting that would increase the amount of verbally responsive language input that children would receive from their moms. And we called the 2 following commenting and interpreting or expanding child communication acts. So I'll talk a little about those. So in following commenting, the parent notices what the child is doing, not just during play, but during other daily routines as well. So if she's changing a child's diaper, or giving the child a bath, or letting the child help with setting the table or making cookies, the parent notices what the child is doing and uses language that describes the child's current focus of attention. So an example so you can look at these two examples. So the child is brushing his teeth. So saying to the child, look at the blue towel over there, would not be following into the child's focus of attention, but saying brush teeth would be. And similarly, if you have this little guy eating a chocolate ice cream cone, saying let's play with the truck would not be following into his focus of attention, but saying, oh, chocolate ice cream would be following into his focus of attention. And then this last one, saying put the blocks in the cup while the child is stacking blocks, is not following into his focus of attention. It's redirecting him to do something else. So saying red block on top would be following into his focus of attention. So the idea is that if the parent can create a match between the language that the child is hearing and what the child is actually doing in his environment, that will make it easier for the child to learn new vocabulary words and sentence structure. So that's following commenting. So in addition to following commenting, our next strategy that we taught was to interpret child nonverbal communication acts, or to expand child verbal communication acts. So by interpreting nonverbal communication acts, children have lots of behaviors that they use to communicate with us intentionally, but these behaviors are not necessarily verbal at the very earliest stages of development. So we mean things like pointing or reaching or showing an object. The moms needed to be taught to even recognize that those were communication acts by the child, and then we taught them to interpret them, which means to put into words the meaning that the child is trying to communicate with their nonverbal communication acts. And by expanding, we mean adding a word or two to a verbal communication act that the child is producing. So if the child says truck, the mom might say red truck, or red truck going up. So the child is communicating about the truck. He's interested in his activity with the truck, and the mom is adding some lexical or grammatical information to the child's communication act. So again, creating a match between what the child is doing or communicating about and the language that the child is hearing. So if the child said toothbrush, the mom might say blue toothbrush. Or if the child reached for some ice cream, the mom could put his reaching gesture into words by saying, you want chocolate ice cream. Or if the child reached for the red block and said red, the mom could say red block. So it's giving the child, it's adding some information to what the child is currently doing. Now we had one additional strategy. So very often children may not communicate often enough for parents to have enough opportunities to use interpreting and expanding as language support strategies. So we also taught moms to use indirect prompting. And by indirect prompting, I'm using that term in contrast to a direct prompting strategy where the mom might say blue, or say cookie. So these are more indirect in that you're arranging the environment to increase the child's motivation to produce a communication act, and then you're able to respond to that communication act with interpreting a nonverbal act or expanding a verbal communication act. And the point of using these indirect prompting strategies is to increase the number of opportunities that moms have to use interpreting and expanding. So I'm sure many of you have heard of environmental arrangement strategies, like having the materials in sight or out of reach, so that when the child wants the material, they have to communicate for it. So I want to just mention another theoretical construct that's kind of very close to the idea of parents using verbally responsive language input. So remember that what we're trying to do here is increase the amount of verbal information that the child is hearing that corresponds to what he's doing or communicating about. So another construct that this matches up with really nicely is the idea of symbol-infused joint engagement, which simply means that the mother and the child are engaged together and the mother is infusing the interaction with symbols, with language input. Okay, so there are two types of symbol-infused joint engagement. One is called supported joint engagement, symbol-infused supported joint engagement, and the other is called symbol-infused coordinated joint engagement. So in symbol-infused supported joint engagement, the mother and child engage in some sort of object-focused interaction, and the mother talks about the child's focus of attention. And it's not even necessary for the child to acknowledge that the mom is talking to them. They're just hearing this language input that corresponds to what they're doing. So the idea is that our strategy of using following commenting or descriptive talking maps pretty much onto this concept of symbol-infused supported joint engagement. And similarly, in symbol-infused coordinated joint engagement, the mother and child are engaged in an object-focused interaction, and the child takes a more active role in communicating something to the mom. And that corresponds to our use of interpreting or expanding. So the child first communicates. The child is an active player in the interaction as opposed to in supported joint engagement. And the mom infuses symbols into the interaction by interpreting the child's nonverbal communication acts, putting into words the child's nonverbal communication acts, or adding a word or two and expanding the child's verbal communication acts. So just to give you an idea of the theory behind the selection of these strategies. Okay, so now I want to talk a little bit about Fragile X syndrome. So Fragile X is the leading cause of inherited intellectual disability. And it's caused by a mutation in the FMR1 gene on the X chromosome, which I guess is enough to say about it. And the mutation on the X chromosome causes the gene to stop production of its gene-related protein, which is called the Fragile X mental retardation protein. And that protein is really important for neural plasticity and experience-dependent learning. Now, because females have two X chromosomes, if they have one X chromosome that's affected, they still have the other X chromosome that's producing the Fragile X mental retardation protein. And so they're somewhat protected from the effects of having Fragile X syndrome. But in males, because they have one X and one Y chromosome, if they don't have the protein produced by the X chromosome, they're really severely affected. So, males with Fragile X syndrome, about 85% of them have IQs below 70, so in the range of intellectual impairment. And the syndrome is associated with a large group of other behavioral characteristics in males. And so I've already talked about that. So almost all males with Fragile X have language delays. They have extreme social anxiety, so as much as they would like to interact with people, it's really anxiety producing for them. They are hyperactive and inattentive. They are hyperaroused because the absence of the Fragile X mental retardation protein interferes with glucose metabolism in the brain, and so there's an excess of GABA, which causes a neurotransmitter that causes hyperarousal. They have symptoms of autism like poor eye contact and perseverative speech and repetitive behaviors. and they also engage in a number of self-injurious behaviors and aggression. So before, Wendy's going to talk to you in a lot more detail about the self-injurious and challenging behaviors that are experienced by young boys with Fragile X syndrome, but I want to show you this graph first. So this is a graph that in this study, a group of researchers at the University of Kansas looked at the effect of early and sustained parent or maternal verbal responsiveness on the language outcomes of a large group of children with Fragile X. So the blue line represents a child with Fragile X that has few symptoms of autism, but a highly responsive mom. So when the mom is verbally responsive for early and a sustained period of time, those children have the best language outcomes. And you can see that the red line is children with Fragile X with no symptoms of autism that have moms that are not very responsive. So you can see there's a pretty big difference in the trajectory of the blue line and the red line. So the green line is children with Fragile X who do have symptoms of autism, but who also have highly responsive moms. So what you can see is that having a mom that's highly responsive can really be protective of the effects of autism and Fragile X, in that children with Fragile X, even when they have autism, but they have a highly responsive mom, they can have better language outcomes than children who have Fragile X and autism that have moms that are not very responsive, which is the black line. So the take-home message from this slide, this is the only published study of maternal responsiveness in Fragile X syndrome, but it tells the story that having a highly responsive mom can really impact language development in children with Fragile X in a big way.
So although responsive mothers in particular are mediating factors in language development for young children with Fragile X syndrome, particularly when they have comorbid autism, as Andy showed, they often engage in serious challenging behavior that can disrupt efforts at intervention, particularly such serious challenging behaviors such as self-injurious behavior, including hand biting or aggression, and other disruptive behaviors related to their behavioral phenotype. Self-injurious behaviors are especially prevalent in males with Fragile X syndrome, with an estimated prevalence rate of 58% of boys. So the young boys in our study were actually demonstrating this prevalence. Our evidence really supports that. Moreover, individuals with Fragile X syndrome seem to engage in challenging behavior to obtain or avoid particular consequences. Specifically, they're more likely than individuals with other neurodevelopmental disabilities to engage in challenging behavior to obtain preferred items or activities and to escape from demands, everyday kinds of demands, and less likely to engage in challenging behavior to obtain adult attention. Now, for young children with autism and other age individuals with autism, those individuals are more likely to engage in challenging behavior to escape from demands, which is not surprising, but also to obtain adult attention. Now, our own recently completed study included an analysis of the challenging behavior for the 12 boys who participated in our study. And we did two kinds of assessments to assess the social consequences that may be maintaining their challenging behavior, as well as some non-social consequences. The two kinds of assessments that we did, and that are considered the gold standard in neurodevelopmental disabilities, particularly as it pertains to the assessment of challenging behavior and the environmental consequences that may be maintaining it, or said another way, the operant function of challenging behavior, are the questions about behavioral function, which is a 25-item rating scale that parents complete to indicate the likelihood of challenging behavior under certain social conditions, and an experimental functional analysis. On the first column, you see the results of our questions about behavioral function, which again is that informal parent rating scale. And we see that parents most often say that their child engages in challenging behavior to obtain preferred items or activities and to escape from demands, whether that's transitioning outside, taking a bath, going to bed, those kinds of things. And our experimental functional analysis, which is a direct observation and the only way to experimentally prove the social consequences of maintaining a challenging behavior, indicated the same thing for 4 of our 12 children. It's important to note that for 7 of the children, there was partial agreement, which is what we find in other studies comparing informal measures to direct observations of the challenging behavior. And for one participant, participant 10, we did not have agreement. Now, within the experimental functional analysis, what we do is have the mother actually implement very specific, highly controlled social conditions, which reflect the kinds of social conditions that a child would experience throughout their day. This includes a demand condition, which is a pre-academic demand condition, such as stringing beads, putting a puzzle together, putting shapes in the shape sorter. A tangible condition, which includes having the child have brief access to a highly preferred toy, and then taking that item away. We also implemented social avoidance conditions, whereby the mother interacted with the child at a very high rate of social interaction, and as well in a diverted adult attention condition. Now, what we're looking for within the experimental functional analysis is a high rate of challenging behavior during one or more of those social conditions. There's clearly a link between limited communication skills of children with neurodevelopmental disabilities in general, and certainly young boys who have Fragile X syndrome. Challenging behavior is a form of communication for these children, and oftentimes when they have limited communication, the way that they express their needs and wants is through challenging behavior. Now, for our boys, we're not going to share the results in detail here, but in summary, I can tell you that the 12 children engaged in a variety of topographies of quite serious challenging behavior that was disruptive to intervention. So it was important for us to focus on addressing the challenging behavior and certainly preventing it from happening during the intervention session so that the mom could uptake the intervention and gain some new skills. The kinds of challenging behaviors we saw included aggression, self-injurious behavior, elopement, which is running out of the room, of course. And many of these challenging behaviors are obviously typical for children this age, but they existed at a higher rate than one would expect of typically developing children of this age, and certainly was compounded by their limited communication skills. So while in an experimental functional analysis, a typically developing child would ask for that toy, the child with Fragile X syndrome would often just escalate to tantruming or hitting their mother. Now, for an intervention such as ours, a naturalistic intervention, which is play-based, it poses a lot of difficulty for children who have Fragile X syndrome. Particularly, they have limited play skills. So play may be seen as a demand by that child, and it may be difficult for the mom to engage them in those activities, which is necessary for the speech therapist to be able to coach them in new language facilitation strategies. The mom may also, or mom and the dad, of course, and other caregivers, may restrict their participation or engagement in community and family life. So they may rearrange the circumstances around mealtime or bath time or bedtime, for instance, because of challenging behavior that the child engages in to obtain things that they really want or to escape from things. Now, thankfully, a growing body of research demonstrates that for individuals with genetic syndromes, including Fragile X syndrome, that their challenging behavior is sensitive to environmental antecedents and consequences. So although they have this behavioral phenotype, which contributes to the likelihood of their challenging behavior, we can carefully arrange the antecedents and consequences in such a way to decrease the likelihood of that challenging behavior. For instance, Hall et al. Evaluated the effects of antecedent social and performance demands on the social escape behaviors, including self-injurious behavior, of 114 school-aged children with Fragile X, and found that social escape behavior is more likely during demands where the child needed to socially interact with another person. And I'm sure that's not surprising for those of you who work with individuals with Fragile X. This was an important implication for our naturalistic language intervention because there's a speech therapist present coaching the mother, and the child must want to interact with the mother, but we have this barrier of a number of barriers, including challenging behavior. So this really led us to develop our collaborative model of treatment for these children and their families. The way in which an overview of our collaboration, we actually included behavioral assessments, including the two that I mentioned previously, into our pre-treatment evaluation. So in addition to assessing developmental age and language age, and autism severity, we also assessed the challenging behavior so that we could develop a proactive behavior plan that would fit the needs of most of the children who were receiving the intervention. Now, the second professional who collaborated with the speech therapist was a board-certified assistant behavior analyst under the supervision of a board-certified behavior analyst, and was able to provide information and training and support to the speech therapist in addressing challenging behavior that may disrupt intervention sessions. Now, this model of collaboration, this transdisciplinary teaming and collaboration, is not a new one, and it's one that early childhood professionals have accepted as the way to go for intervention for children and families who have multiple disabilities. Our own model included collaborative problem solving throughout the intervention, baseline assessment, which included the experimental functional analysis to give us an idea of what challenging behaviors may disrupt family routines at home during the intervention. And our intervention included a proactive behavior support plan and collaborative coaching with the behavior specialist playing the secondary consultant role to the speech therapist via distance technology. So our focus was on language, and the addressing challenging behavior took a back seat in some ways, but we knew that eliminating challenging behavior could make it so that the parent could implement the intervention with higher fidelity, and certainly allow the speech therapist to coach more often, give more frequent opportunities during family routines. Now, the BCBA and speech therapist worked together to create a proactive behavior support plan that included all of the components that are typically included in an effective function-based behavior plan. And by function-based, I mean it meets the function of the child's behavior, the operant function. However, we were limited in some ways by wanting to focus on language within the context of a naturalistic intervention. So we focused on antecedent and motivating variable manipulation rather than consequences, so that it would fit nicely within play-based intervention where we're following the child's lead. Now, this included addressing motivational variables that may affect the likelihood that a child engages in challenging behavior to obtain a particular reinforcer, like escaping from an activity or getting that iPad that's in the other room. And that included a neutralizing routine, such as having the parent blow bubbles before they start the intervention, which would be a presumed highly preferred activity for some children, obviously. We'd work that out. And then behavioral momentum. Antecedent manipulations included choice making and using preferred activities, which actually overlaps with a naturalistic intervention philosophy. The consequence-based strategies included providing two choices contingent on wandering and lack of engagement, and non-contingent reinforcement, and extinction. Now, for some children, they required additional strategies, including functional communication training, specifically teaching a functional communication phrase or sign for them to match the function of their challenging behavior. So if they were routinely engaging in challenging behavior to obtain a train, which was on a shelf, rather than engaging in an appropriate communication act, then they were taught a way to ask for that train appropriately. Our broad intervention goals were to provide mothers not only with a way to enhance verbal language input, but also to support the existing communication and language, to encourage engagement and play in other family routines, and to decrease challenging behavior. We also wanted it to be cost-effective, something that could be implemented in the natural environment, meaning the parent's home, and community, and accessible regardless of geographic location. Geographic location was really important to us because our families, because Fragile X's low incidence disability, were spread across the United States. As you can see, the stars indicate where our families were living at the time of intervention. This brought us to using distance video teleconferencing, which has been used successfully by medical professionals and increasingly by educational and special education professionals to deliver intervention at a distance and to alleviate specialist shortages and to improve access for individuals, whether that be access problems via low incidence disabilities or geographic location. Now, the video conferencing we used was desktop video teleconferencing using a laptop computer at the Mind Institute or at the University of Oregon and a laptop computer in the family's home, Skype and Dropbox to share instructional materials.
Okay, so just to kind of summarize everything Andy and Wendy have talked about, we had 3 main goals of the current project. We really wanted to teach mothers how to use responsive, child-centered strategies to interact with their child to support language learning. We wanted to provide mothers with a set of behavior support strategies so that they could use those strategies in order to implement the language support strategies. And we also wanted to evaluate the effectiveness of combining face-to-face clinician coaching of a mother-child interaction with clinician coaching delivered by distance. Okay, so I'm just going to talk about some preliminary findings of 3 of the mother-child dyads that participated in the larger project. And because we're still in the beginning stages of analyzing the data, I'm only going to be talking about the language support strategies. So we had 3 research questions for this small study. We asked, does the intervention result in changes in maternal use of targeted language support strategies? Does the intervention result in changes in time spent in supported and coordinated joint engagement? And does maternal use of targeted language support strategies occur as frequently during distance video teleconferencing as during on-site sessions? Okay, so this study was a non-concurrent multiple baseline design across 3 naturalistic teaching strategies, and Andy talked about these. Our first strategy we taught moms was how to use following commenting. Second strategy was indirect prompting of child communication acts, and what we focused on here was using environmental arrangement strategies like bit by bit and inside out of reach, and choice making and time delay. And then we also taught moms how to respond to their child's communication acts by interpreting or expanding. Okay, so again, this data is just from 3 of the dyads that took part in our larger project. And as you can see, all were young boys with Fragile X syndrome, and they all had delays in cognition and language. Okay, so I just want to give you an overview of the intervention program and the structure. So the intervention program lasted a total of 7 months and consisted of both on-site and distance sessions. There were a total of 5 monthly on-site sessions, which are in yellow, and 13 distance sessions, which are in red. During the pre-intervention assessment, the parent and the child came to the Mind Institute. We completed a variety of language assessments and behavior assessments, which Wendy talked about. And they also completed 5 5-minute play-based interaction sessions. So we just put them in a room with some toys and told the mom to interact with the child like she typically would. And that's where we got our baseline data. So the 4 monthly on-site sessions each consisted of a 90-minute mother education session. During that session, the clinician sat down with the mom, went over a PowerPoint presentation that detailed the strategies for that month. And that was immediately followed by a 60-minute clinician coaching of a play-based mother-child interaction. And during that time, the clinician helped the mom to engage her child in play and implement the strategies that she just learned. The clinician gave her feedback, used verbal praise and verbal models of what to say and do. And then about halfway through each clinician coaching session, the clinician stepped out of the room and a 5-minute sample of just the mom and the child playing was taken, and that served as their data. The 12 distance coaching sessions occurred in the participant's home, and like Wendy said, we gave each family a Mac laptop computer with Skype installed, and each session lasted about 60 minutes, and again, that 5-minute sample was taken about halfway through. And as you can see from this chart, 3 weekly distance sessions followed each on-site visit, so the mom had time to practice the strategies we taught her. The post-intervention session occurred in month 5, and we had a 3-month follow-up session by distance in month 7. Each month, we introduced a new language strategy, like I said. So month 1 was following commenting. Month 2 was indirect prompting of child communication acts. Month 3 was interpreting and expanding, and during month 4, we focused on generalizing those 3 strategies that we taught to other routines, like toothbrushing and bath time and dressing. All mother-child dyads in this study, not just the 3 I'm going to talk about, but all of them completed all on-site sessions and all distance sessions, so compliance ratings were 100%. Okay, so turning to the results, research question 1, again, was does the intervention result in changes in maternal use of targeted language support strategies? So for this first research question, I'll present single subject graphs for each of the 3 dyads. Okay, so here are the results for dyad 1. And for all these single subject graphs, each tier represents a different language support strategy. So this first one is following commenting, indirect prompting, and interpreting and expanding. The x-axis shows the sessions going from 1 to 22, and the y-axis shows the percent of intervals in which the target strategy occurred. And just note the different metrics on each of the y-axes. So looking at this first tier, the red line corresponds to the mother's use of the strategy, and the black line is the mean line for that strategy. So here's the mean line for the baseline sessions and the mean line for intervention sessions. This line here separates the baseline sessions from the intervention sessions for each strategy, and then this line separates the intervention from the follow-up. So hopefully that helps a little bit. Okay, so looking at the first tier, you can see that during the baseline sessions, before we introduced following commenting to the mom, she was using following commenting about 45% of the time on average. And then after we intervened in session 6 here, she increased her levels to about 60%. So already, before intervention, this mom was already fairly good at talking about her child's focus of attention. But after we introduced the strategy, she did increase and use the strategy more than half the time. Looking at indirect prompting, during baseline, the mother prompted her child's communication less than 1% of the time. And then after we intervened in session 10 here, the mother increased her use of this strategy, but only slightly, spending an average of about 5% of the time prompting her child's communication. So in the case of this mother-child dyad, this child did frequently initiate communication, so the mother didn't have to use this strategy very often. But we still decided to teach her how to implement the strategy, since there were times and situations where her child didn't initiate communication. And then looking at maternal use of interpreting and expanding. So for this last tier, for all the graphs I'll show you, I've also included the child data. So I'm not going to really talk about child data today, but I included it here so that you can see the correspondence between child communication acts, so these are prompted and spontaneous communication acts in blue, and the mother's response. So you can see that after we intervened in session 14, there was a closer match between the child communication act and the parent response to those communication acts. Okay, so a couple things to point out before I move on to the next dyad. You can see that there's an upward trend in the baseline for following commenting and for interpreting and expanding. And there's also some overlap between baselines and intervention for the strategies. So these things limits our ability to say that the intervention itself was the result of the changes in the mom's use of the strategies, but we did see increases in the mean lines after we introduced the strategy. Okay. So turning to dyad 2, looking at maternal use of following commenting. During baseline, the mother used this strategy about 37% of the time, and after we intervened, mean levels went up to 68%. Similar findings to indirect prompting. The mom used the strategy less than 1% of the time during baseline, and after we intervened in session 6, mean levels increased to 17%. Looking at maternal use of interpreting and expanding, you can see that about beginning in session 7 here, there started to become a closer correspondence between the Child Communication Acts and the parent response. So session 6 was when we introduced the first strategy following commenting. So for this mom, it was like being in the intervention itself made her more responsive to her child's communication acts. And then she maintained her responsiveness throughout the rest of the intervention. So this dot's just way down here because in this session, the child didn't have any communication acts. Okay, and then looking at dyad 3, following commenting, during baseline, the mom used this strategy about 37% of the time, and then after we intervened, mean levels increased to 68%. And then indirect prompting. During baseline, the mom did not use any indirect prompting strategies, and after we intervened, mean levels went up to 7. And then interpreting and expanding, you can see that after we intervened here, there's a closer correspondence between child communication acts and parent response.
Okay, so turning to research question 2, we asked, does the intervention result in changes in time spent in supported and coordinated joint engagement? So what we really wanted to do here was make a shift in the distribution of engagement. During a play-based mother-child interaction, we wanted to decrease the amount of time the child spent in a not engaged state or in a state of solitary object-focused engagement, and increase the time spent in states of supported joint engagement and coordinated joint engagement. So the data were very consistent across all the dyads, so in the interest of time, we've collapsed the 3 dyads into one graph to show the average % of intervals spent in the different states of engagement. The pre-intervention baseline sessions are shown in blue, the on-site intervention sessions are shown in red, and the distance intervention sessions are shown in green. As you can see, the time spent in a not engaged state decreased from baseline to intervention, and you can also see that on average the children were more engaged at home, which is shown in green, than they were here in the clinic, which is shown in red. Sole object-focused engagement also decreased from baseline to intervention. There was a substantial increase in supported joint engagement from baseline to intervention, and a slight increase in coordinated joint engagement from baseline to intervention. So looking at our last research question, we asked, does maternal use of targeted language support strategies occur as frequently during distance sessions as during on-site sessions? This graph shows the % of intervals in which the mother used a targeted language support strategy during on-site sessions compared to distance sessions. And again, this graph is averaged across the 3 dyads since the data was similar. On-site sessions are in blue and distance sessions are in red. As you can see, mother's use of each of the 3 strategies is comparable across both contexts. And this is a similar finding to the 2013 McDuffie et al. Paper, in which an earlier version of this intervention was used with young children with ASD. So overall, from these 3 mother-child dyads, we showed that the intervention increased maternal use of the targeted language support strategies. The intervention also increased the amount of time that the mother and child spent in states of joint engagement. And we demonstrated that maternal behaviors and joint engagement were comparable during both on-site and distance sessions. So overall, we received positive feedback about the intervention from mothers who participated. But in thinking about future directions, we have a couple of questions we think are important for discussion. One question we have is, can we decrease the number of on-site visits? Since traveling to the Mind Institute once a month for 5 months is really challenging for these families, we wonder if we'd be able to reduce the number of on-site visits and conduct more of the intervention via distance. Another question we have is about the number of distance sessions we should have a week. Some parents liked having them 1 time a week, and others wanted more. So we're still trying to figure out what's the optimal number of distance sessions to have in 1 week. We also wonder if we can implement this intervention with more than 1 affected child in a family. And can we teach these strategies to dads or other caregivers in addition to mothers? Out of the 12 children that participated in the larger intervention project, 7 of those children were nonverbal communicators. We didn't have a set mode of communication we used during the intervention and just worked with what they came in with. So if a parent was working on sign language with their child, we worked on sign language. But we wonder if we can develop some sort of assessment process to identify the preferred mode of communication for children who are nonverbal communicators. We also wonder if we can incorporate more of a focus on daily routines. This was something parents really liked us to work on, especially those difficult routines. So we wonder, can we do more with daily routines and not just play? Another thing we're wondering is, can we enhance the effect of this intervention by adding a pharmacological treatment? There are many clinical trials going on with Fragile X syndrome, so we wonder if we can add this to those clinical trials. So we just wanted to thank the National Fragile X Foundation for funding this project, our current and past collaborators, and most of all, the families who participated in this research. Thank you very much.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.